Hello, it's Dmitry again. Today I'll be doing another video from Mehlman Medical PDF for the internal medicine PDF, particularly referring to the section and chapter, you could say, on gastroenterology. So before we went over the cardiovascular chapter and went over the pulmonary chapter, we're going to actually skip the renal chapter, at least for now, and go into the gastro chapter. This will be a part one of this section. I suspect at least another video after this one, probably tomorrow. Maybe there'll be a third video. I'm not sure. It is a longer chapter than the other two in terms of how many pages there are, although that doesn't necessarily mean the amount of content per se is more. We'll just have to see. So let's get into it. Gastro. Disorders affecting lips/oral cavity for internal medicine. Peutz-Jeghers syndrome, I guess I would say Peutz-Jeghers, but Peutz-Jeghers syndrome. Peutz-Jeghers syndrome. Disorders of, so Peutz-Jeghers syndrome. Combination of perioral melanosis, fancy word for hyperpigmentation around the lips/mouth, plus hamartomatous colonic polyps. USMLE will show you image of lips pretty much always, and then they'll ask for what kind of polyps are seen in the colon, that is to say hyperplastic, tubovilus, etc. And the answer is just hamartomatous. So remember that, hamartomatous, for Peutz-Jeghers syndrome for that. Osler-Weber-Rendu syndrome, aka hereditary hemorrhagic telangiectasia, autosomal dominant. NBME loves showing a mouth or fingernail picture of telangiectasias. Question will give nosebleeds plus show you above the above picture. There can be a high output cardiac failure due to pulmonary AV fistula. GI bleeding can occur leading to anemia. And you can see there the Osler-Weber-Rendu. You can see the telangiectasias of the lips and the mouth, like the lips, that kind of thing, lips and tongue. Okay. What about Plummer-Vinson syndrome? Triad of iron deficiency anemia plus esophageal webs, dysphagia plus angular cheilitis, or cheilitis, I would say, cracked corners of the mouth. So this is because of iron deficiency, esophageal web, which is why you have an iron deficiency, and also the angular cheilitis. NBME question can also mention pica, iron deficiency sign where the patient eats clay, starch, or ice, or they can show spoon-shaped nails, koilonychia, which are a sign of severe iron deficiency. Lip psoriasis. Just know it's possible. USMLE can mention it on upper lip or forehead, and this somehow confuses students where they think it has to be on the extensors only, but it doesn't necessarily have to be. Aphthous ulcer, aka canker sore, usually appears as very painful lesion, self-resolving lesion on labial mucosa, not infective, idiopathic, thought to have very mild autoimmune association, sometimes associated with certain triggers like spicy food. Kawasaki disease, vasculitis that is caused by 5+ days of fever plus injected red eyes and/or lips/tongue, plus cervical lymphadenopathy, plus edema or dorsa of the hands, plus desquamation of palms and soles, often mentioned as palm/soles, rash, but not true rash. Students obsess over coronary artery aneurysms as though they are so high yield. They're not. USMLE basically never mentions them. Perioral impetigo, often confused with herpes. Well, I can see why. If they show you an image of a young kid, in particular with lips lesions, it's usually impetigo caused by Staph aureus or group A strep pyogenes. Can lead to PSGN, post-streptococcal glomerulonephritis, if caused by strep, as discussed in the high-yield renal PDF. Herpes labialis, caused by HSV1 or 2. USMLE doesn't care about HSV1 being the lips and HSV2 being the genitals. Bunch of nonsense perpetuated by other resources. I'm not quite sure what he means by that. Listen, HSV1 is predominantly oral, like around the face, like the mouth and stuff, like the lips and so forth, and HSV2 is primarily genital. I don't. You can understand why, and it's HSV2 traditionally would be an STD for obvious reasons, in a way that HSV1 would not be. However, it's also correct to say that you can get HSV1 genitally and you can get HSV2 orally. Now, HSV2 orally, HSV2 is a quote-unquote genital herpes. You can get it orally, but it's not super common to get. HSV1 is traditionally oral herpes, and it is becoming increasingly common genitally. And the reason is, you can imagine, I think we can put two and two together with that one. Basically, most of the population has oral herpes because it's not from sex necessarily. They're getting it from other things, right? They're getting it from various secretions and so forth. It happens. A lot of people have HSV1 oral herpes. The thing is, though, there's an increasing amount of a certain behavior that involves mouth and genital contact, and as a consequence of that, more of that happening, there's more people who have genital herpes that's actually HSV1, which, despite the fact that HSV1 is basically traditionally oral herpes, and is in fact probably adapted for the face and the mouth. So, which is interesting. Not a fan of that happening, but from a purely psychosociosexual phenomenon, it's an interesting one, I guess. Anyway, so yeah, it's not exclusive to one of the. Just know that HSV1 is traditionally oral, HSV2 is traditionally genital, but it does not mean that you can't get the other from the other, because let's be honest, people are doing all sorts of things that give them diseases, as you can imagine. Primary infections present with fever and regional lymphadenopathy. Recurrences aren't as severe. HSV goes latent in sensory nerves. USMLE will show you a buff pic, and then the answer is DNA, enveloped, linear. Sounds nitpicky and low yield, but it's one of the viral structures they like asking. Don't confuse with Hep B, which is DNA enveloped circular. I've made lots of YouTube clips on that stuff. Because again, for herpes, remember, it's DNA enveloped linear, okay? Treat with acyclovir, DNA polymerase inhibitor causing chain termination. HSV resistance to it will be due to altered thymidine kinase. Scarlet fever, caused by group A strep. Causes strawberry tongue/red lips plus salmon pink maculopapular body rash. Treatment is penicillin to prevent rheumatic fever, type 2 hypersensitivity. Can also lead to PSGN, type 3 hypersensitivity. I discussed this stuff in the high yield cardio and renal PDFs. Hand, foot, mouth, caused by Coxsackie A, an RNA virus under Picornaviridae. Causes benign but contagious lesions on, you guessed it, lol, the hands, feet, and mouth. Yeah. It's pretty self-explanatory. They say Coxsackie virus A. Okay. Usually pediatric, but can present in adults like daycare workers and parents. Do not confuse with Coxsackie virus B, which can cause dilated cardiomyopathy, diabetes type 1, and pleurodenia, latter, which is also called devil's grip. Latter I discussed in high-yield pulmonary PDF. Herpangina, also caused by Coxsackie virus A, presents as an oropharyngeal vesicles or sores. And you can see that right there in the picture. Can occur with or without hand, foot, mouth. So you can have herpangina without necessarily getting hand, foot, mouth disease. Koplik spots, caused by measles, white/bluish spots on buccal mucosa. One of the ways to distinguish measles rubiola from rubella, German measles. The same way you can memorize Koplik spots is unique to measles, you should memorize suboccipital and post-auricular lymphadenopathy as unique to rubella. Both measles and rubella have a head-to-toe maculopapular body rash. Both can present with fever, cough, coryza, conjunctivitis. These findings are nonspecific for viral infection. It's been erroneously attributed to only measles over the years, but I've it show up they probably mean I've seen it show up in numerous NBME questions for a variety of viruses. So be careful. Sialolithiasis. Stones within the ducts of the salivary glands. Stenson duct is the opening of the parotid gland from parotid gland into the oral cavity, which is located near the second upper molar bilaterally. Sometimes a question can say a patient has a pain or inflammation on the buccal mucosa across from the second upper molar, and sialadenitis, inflammation, or sialolithiasis can be an answer. Leukoplakia. Leukoplakia, whitish, painless, rough patch on lateral tongue. Precursor to squamous cell carcinoma of the tongue. Biggest risk factor is smoking and chewing tobacco. Oral hairy leukoplakia. Looks like a leukoplakia, but caused by Epstein-Barr virus, or EBV. Not considered premalignant, no dysplasia on biopsy. Oropharyngeal candidiasis. Painless white plaque on palate or tongue that bleeds when scraped. Yeah. Seen in immunocompromised patients such as AIDS or organ transplant recipients on immunosuppressant agents. Can be seen in patients with asthma who use inhaled corticosteroids. Patients need to rinse their mouth with water after use to decrease the candida risk. Treatment would be with nystatin mouthwash. Adenophagia, or painful swallowing, is an immunocompromised patient is candidal esophagitis until proven otherwise. Here we go. Let's go. Salivary gland neoplasia. I think what's going to happen, this is my prediction here. You'll see if I'm right or wrong, I guess, is they started with the mouth and they go all the way at the end of the chapter of gastro to the rectum. That's my assumption. So let's see if that works, if that's true. You can, if you're watching this, you can figure out by the end, right? Salivary gland neoplasia. Pleomorphic adenoma. The answer on USMLE for benign salivary gland tumor that has variability in cell size and shape. Most common salivary gland tumor, benign. Pleomorphic, cells and nuclei have variability in size and shape. Mucoepidermoid carcinoma. The answer on USMLE for a salivary gland tumor that invades has spread if the patient has B symptoms, fever, night sweats, weight loss. Most common malignant salivary gland tumor, mucoepidermoid is the most common. Malignant means capable of invading, whereas pleomorphic adenoma will not invade. What about a Warthin tumor? Warthin tumor is the answer on the USMLE for salivary gland tumor where they say anything about it resembling lymphatic tissue. Okay, anything about it resembling lymphatic tissue. Salivary gland tumor that has lymphoid stroma, that is to say, looks like lymphatic tissue. I'm going to take a brief break. Okay, we're back. High-yield esophageal conditions for internal medicine. So basically, I think my suspicion's correct, because we're going to the esophagus now. Hiatal hernia. Herniation of the stomach upward through the diaphragm. 95% of the time, hiatal hernia is known as sliding, where the cardia of the stomach rises upward through the esophageal hiatus, opening in diaphragm where the esophagus passes. Abnormal relation of the cardia to the lower end of the diaphragm is the answer on NBME. I love these phrasing. I shouldn't say I love. It's the opposite of love. It's frustrated, you could say. Or irritated, irate. I don't know. Where they will never say they don't like saying the answer up front. They don't like saying, oh, well, yeah, of course he has hiatal hernia, of course. They say, abnormal relation of the cardia to the lower end of the diaphragm. It's like, oh, okay. Whatever. And maybe that's easier to understand because you're understanding from like a mechanistic, like theoretical concept of what is it in the first place. But, you know, it's just a weird thing that the phrasing is interesting. So anyway, that's the phrasing for NBME. 5% of the time, it is the paraesophageal, where the fundus of the stomach herniates upward through a hole in the diaphragm adjacent to the esophagus. Protrusion of the fundus into the chest above the level of T10 equals the answer for paraesophageal hernia on NBME. So here's the sliding hernia. You can see the herniated gastricardia. So that's one type, which is called the sliding hiatal hernia. They say sliding hiatus hernia, but I would say hiatal hernia. So the sliding hiatal hernia, the herniated gastricardia like that. The other kind is where it kind of has this little out pouch, which is that's called the paraesophageal hiatal hernia, where you have a herniated gastric fundus, defect in the phrenoesophageal membrane. Okay, so two different ways it can happen. Often associated with gastroesophageal reflux disease or GERD, diagnosed with the upper endoscopy, operate to repair is the treatment. Here's GERD. GERD, or gastroesophageal reflux disease, irritation of esophageal mucosa by gastric acid, usually caused by the lower esophageal decrease in the lower esophageal sphincter tone, LES tone. USMLE wants you to know obesity is a risk factor for GERD, likely due to the increased stretching and pressure applied to the lower esophageal sphincter. As mentioned above, hiatal hernia is also a risk factor. Classical presentation is burning in the throat/chest after eating a meal, can present with nocturnal cough or recurrent pneumonitis. These are high-yield findings in patients who don't have classic esophageal irritation symptoms. Can lead to Barrett esophagus, discussed below, which leads to esophageal adenocarcinoma. The first step in diagnosis is 2-week trial of proton pump inhibitor, such as the omeprazole, which will decrease the symptoms. Proton pump inhibitors are more efficacious than H2 blockers, that is to say, like cimetidine. If you see both a PPI and an H2 blocker as answers for a GERD question, choose the proton pump inhibitor. So proton pump inhibitors are like number one, okay? Bear that in mind. When you hear something like omeprazole, go for that. So on 2CK form has a 2-week trial of H2 blocker as an answer, but PPI isn't listed, so just know the question is out there. If the trial of PPI does not work, proton pump inhibitor does not work, 24-hour esophageal pH monitoring is the answer. Okay, if it doesn't work, do a pH monitoring. Okay. Okay. Nissen fundoplication is the last used as the last resort, but is asked on NBME. So basically, number one check you want to go for a proton pump inhibitor like omeprazole. If you don't have a proton pump inhibitor like omeprazole or whatever as an answer, go for an H2 blocker if it's not available. If you don't have proton pump available as a thing. If PPI does not work, what you want to do is do a 24-hour esophageal pH monitoring, and if the last resort is the Nissen fundoplication. So let's continue. Here's a picture here. It says A, fundus wrapped around this backside of the esophagus. Okay. And the other one wrapped securely with sutures. I guess these are different ways to treat it, right? Nissen fundoplication. So you can either wrap it around so there's just not fluid building up there or whatever. It's not causing an issue. And the other one, because it's just like, I guess, this is pulled around, I suppose. Wrapped and secured with sutures to anchor lower esophagus below the diaphragm. So that's the other way you could do it. Just keep it below. Make sure that it doesn't come back up. Answer can be written as fundoplication alone in patients with severe GERD. This also shows up on PEDS, where they say an infant with severe GERD and fundoplication is the answer. Pediatric GERD will present as coughing up milk 2 to 3 times daily. It will not be described as a high energy or forceful, that is to say pyloric stenosis. It will not be bilious, that is to say not duodenal atresia or annular pancreas. It will not occur as choking or spitting up during the first feed, like for example in tracheoesophageal fistula. Answer to the pediatric GERD question is immature lower esophageal sphincter. It's not complicated, but I've seen students say, wait, you can get GERD in kids? And it's like, yeah. Treatment for pediatric GERD is thickened feeds, addition of dry ice to formula. Huh? Okay. Dry rice. Wow, okay. Treatment of pediatric GERD is thickened feeds, addition of dry rice to formula, and position change prior to any use of proton pump inhibitors. You had me there for a moment. Dry rice. Barrett esophagus. Metaplasia of the distal esophagus characterized by conversion of non-keratinized stratified squamous epithelium into columnar epithelium with goblet cells, which secrete mucus. You'll sometimes hear the latter described as intestinal columnar epithelium. This is because the stomach doesn't have goblet cells. It has mucous neck, foveolar cells. Major risk factor for esophageal adenocarcinoma. Squamocolumnar junction and the gastroesophageal junction. Normal esophagus. Squamocolumnar junction, columnar epithelium-lined esophagus, and the gastroesophageal junction. Barrett esophagus. So basically you have this sort of new addition of columnar epithelium in the what would otherwise be the esophagus, and has normal esophageal epithelium, which is normally squamous in nature. And that's relevant to say because it looks like intestinal epithelium. It doesn't necessarily look like stomach epithelium. It looks like intestinal epithelium, right? And so that's kind of uncharacteristic. So just bear that in mind. And it's because of the new environment from all this this gastric acid popping up. It causes this metaplastic change as a way to kind of theoretically accommodate. But that's kind of this process, though, of metaplasia that eventually leads to a potentially like a cancer, you know. So bear that in mind. Can appear grossly red on upper endoscopy. Once visualized, the next best step is biopsy to confirm the presence of Barrett metaplasia. Adenocarcinoma affects the lower third of the esophagus. High-yield pathogenesis is GERD, leading to Barrett esophagus, leading to adenocarcinoma. Will present in patients over 50 who have a history of GERD with either 1. New onset dysphagia to solids, or 2. Dysphagia to solids that progresses to solids and liquids. The new onset of dysphagia can refer to a 3 to 6 month history in patients with, that is a 10 to 20 year history of GERD. Oh, that's foreboding. You have let's say you have a 20-year history of GERD, and then all of a sudden you start having dysphagia. You can't get food down. What's going on with that? Well, maybe something's going on that's more, malignant and more serious and more malicious, and that could be adenocarcinoma. 2CK wants immediate endoscopy in either of the above situations. Immediate endoscopy. Don't choose barium first. Choose endoscopy. Sometimes, rather than making you choose endoscopy straight up, they'll tell you in the last line an endoscopy was performed and shows a stricture. Then they'll ask for the next step. At that point, you want to do a biopsy of the stricture. I'm realizing now how distinct the step 2 is from like the board exams for the first year, because it's super focused on the clinical, like what do you do in this situation, what do you do in this situation, and there's a lot less interest in sort of the physiological and pathological mechanisms. There's more like it's less focused on the pathology and the physiology, and it's more focused on the clinical, So if you've taken step 1, you've taken complex 1, just keep that in mind. Squamous cell carcinoma affects the upper 2/3 of the esophagus. Biggest risk factor for USMLE are heavy smoking and alcohol use. Often risk factors like burns, chemical achalasia, etc. are nonsense. Will present in patients over 50 who is a heavy smoker / drinker who is 1, has new onset dysphagia to solids, or 2, has dysphagia to solids that progresses to solids and liquids. Did I just read that? Yeah. I did, but this is the same thing they said before. Same as with adenocarcinoma, USMLE wants immediate endoscopy as the answer, followed by a biopsy of stricture or lesion if present. Okay, so it's the same thing. The same sort of thing that's going on, not exactly the same mechanism, because it's like, this is about alcohol use and smoking, but otherwise, they notice dysphagia, and all of a sudden they have, it's like adenocarcinoma, it's a cancer in the esophagus, in this case the upper 2/3, but it's some sort of cancer, And the first thing you gotta do is endoscopy. And after endoscopy, if it's a stricture, you gotta go do a biopsy. That's your 1 and 2. What about a Zenker diverticulum? Outpouching of the and you can see that right there as well in the picture. Outpouching of the esophagus above the cricopharyngeus muscle, just above the upper esophageal sphincter. The mechanisms of USMLE are numerous and include cricopharyngeal muscle spasm, uncoordinated swallowing, dysphagia, and increased oropharyngeal pressure. False diverticulum contains only mucosa plus submucosa. True diverticula, in contrast, such as Meckel's diverticulum, include the muscular layer as well. Often presents as overweight male over 40 or 50 with gurgling sounds when swallowing or regurgitation of undigested food. Halitosis or bad breath is buzzy but only mentioned in maybe a third of the questions. Diagnosis is made with barium swallow. Treatment would be on 2-CK NBME is diverticulectomy, so just removing the thing. So again, a false diverticulum is only using the mucosa, submucosa. A true diverticula goes to the actual muscle itself, and that's called a Meckel's diverticulum. Achalasia. Achalasia is a tightening, i.e. increased tone of the lower esophageal sphincter due to a loss of NO or nitric oxide secreting neurons in the Auerbach myenteric plexus. New NBME wants enteric ganglia as the answer for the site of problem. Enteric ganglia can be described on NBME as dilated esophagus with constriction of the gastroesophageal junction. Presents usually as dysphagia to both solids and liquids from the start. This is in contrast to cancer, which will be the new onset dysphagia to just solids or progression from solids only to solids plus liquids. The high yield point is that the neurogenic causes of dysphagia, that is to say achalasia, leads to solids plus liquids dysphagia. Almost always idiopathic, can rarely be caused by Chagas disease. New 2-CK NBME has South American trypanosomiasis as the answer for achalasia, which is aka Chagas disease. So again, South American trypanosomiasis, Chagas disease. Think about that in the context of achalasia, apparently. First step in diagnosis is barium swallow. So again, achalasia is for barium swallow. Sort of similar to what we did for Zenker's diverticulum. Those are barium swallows. Which shows a classic bird's beak appearance, as you can see right there in the picture. After the barium is performed, esophageal manometry, a pressure study, is confirmatory. Biopsy is not traditionally performed. Treatment is pneumatic balloon dilation followed by myotomy, cutting of the muscle fibers of the lower esophageal sphincter, because they're constricting the sphincter and preventing it from allowing things to pass through it. So they have to cut the fibers. Systemic sclerosis, that is to say, scleroderma. As discussed in detail in the high-yield pulmonary PDF, this is an idiopathic autoimmune disease characterized by multi-organ system fibrosis and hardening of the tissues, i.e. sclerosis, can lead to GERD. NBME wants decreased lower esophageal sphincter tone and decreased esophageal peristalsis as an answer for this thing, scleroderma, or systemic sclerosis. This refers to the esophageal dysmotility component of CREST, calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. Esophageal perforation can either be iatrogenic, i.e. from endoscopy, or Boerhaave syndrome from increased pressure due to retching, vomiting, or straining. USMLE likes to say water-soluble contrast swallow shows accumulation in the mediastinum. If they don't mention this, they'll give either recent endoscopy or straining plus acutely low BP and high heart rate, where you have to eliminate the other answers out of reasoning. Water-soluble contrast like gastrographin is used in suspected perforation because the contrast will leak into the mediastinum and barium can cause mediastinitis. Okay. In contrast, no pun intended, haha, if patient has aspiration risk, we use barium and not gastrografin because the latter can cause pneumonitis. Esophageal repair is the treatment on NBME. Pretty straightforward. Again, esophageal perforation, what do? Esophageal repair. Mallory-Weiss tear. Classically, retching slash vomiting in an alcoholic that causes stretching and tearing of the gastroesophageal junction, leading to small amounts of blood and vomitus. Can also occur in patients with eating disorders or hyperemesis gravidarum. It is, to my observation on NBME material, that the highest yield point above MW tear, Mallory-Weiss tear, is that it does not cause high volume hematomesis. If the vignette mentions high volume blood, that is a ruptured varix instead. So not the same thing. Let us take a brief break. Okay, I am back. Let us continue. So, esophageal varices. Enlarged and tortuous superficial esophageal veins due to the portal hypertension in patient with cirrhosis or splenic vein thrombosis. And you can see that there. The mechanism in the setting of cirrhosis. The left gastric vein connects. The mechanism in the setting of cirrhosis. The left gastric vein connects the esophageal veins to the portal vein. In the setting of the increased portal pressure, this pressure backs up to the left gastric vein, which backs up to the esophageal veins. Many USMLE questions want left gastric vein as the answer for the vessel responsible for the varices. In splenic vein thrombosis, the increased splenic venous pressure causes formation of collaterals to circumvent the thrombosis. This means nearby veins will come from small tributaries/branches from the splenic vein. The left gastric vein is one of them, leading to an increase in esophageal venous pressure. It is to my observation on NBME questions that 4 to 5 varices questions will give a patient with a high volume hematemesis. In contrast, Mallory-Weiss tear is just a little blood. Ruptured varices are lethal 50% of the time. The patient will vomit high volumes of blood in esophageal varices. 1 out of 5 questions might say just a little blood if the varix is friable but not overtly ruptured. But the vignette will be obvious, i.e. cirrhosis. Plus, they might ask for a left gastric vein as the answer. Propranolol is prophylaxis, not for acute treatment. Treatment is endoscopy plus banding. Endoscopy plus banding for treatment. The prophylaxis is propranolol. Octreotide can also be used for acute bleeding, but endoscopy plus banding is the best answer on USMLE if you are forced to choose. There is a 2CK question where the patient has a decreased blood pressure significantly decreased blood pressure due to ruptured varix, and the answer is IV fluids, where the endoscopy is the wrong answer. So if it's a radical blood pressure drop, the real first thing you do is IV fluids because the blood pressure is a problem. I've had the students say, wait, but I thought you said endoscopy and banding was what we do first. And my response is, yeah, but you always have to address ABCs first on 2CK. Yeah, if the guy's going to die because of his severe hypotension, you got to do something about that first. They could by all means say outpatient has O2 sats at 50%, and the answer would be give oxygen before fluids. The diffuse esophageal spasm. Idiopathic spasm of the esophagus. All you need to know is that this causes pain that can mimic angina pectoris, but patient will be negative for cardiac findings and disease. So that's the esophageal spasm. Barium shows a corkscrew appearance. That's weird, which you can see there. Nutcracker esophagus is a similar condition that is due to the idiopathic hyperperistalsis that causes pain similar to DES, the diffuse esophageal spasm. So it's similar, but not the same thing. Eosinophilic esophagitis. Idiopathic allergic condition of the esophagus that presents with difficulty swallowing. Biopsy shows eosinophils in epithelium. It's like, yeah. Endoscopy shows trachealization of the esophagus with concentric rings. Patient might have history of asthma or atopy. Schatzky's ring. Garbage diagnosis for USMLE does not exist. Mentioning it here as a negative for USMLE caring because otherwise someone will be like, Mike, you didn't mention Schatzky ring. Technically, a narrowing of the distal esophagus that could be considered as a differential alongside achalasia. Once again, never seen this assessed as a correct answer on NBME material, maybe just one as a distractor, garbage diagnosis. So the answer is if you see Schatzky ring on an NBME exam, That's probably not the answer. You can just probably ignore that and cross it off, okay? Now we're going into our next section. We're on high-yield GI endocrine hormones, quick review. Now we're on page 113. I don't remember what page we're supposed to finish up on. It's more than 40 pages for this one, I believe. But again, the earlier pages were not too crazy. So, yeah, what are you going to do? High-yield GI endocrine hormones, quick review. Insulin, produced by beta islet cells in the tail of pancreas, decrease blood glucose by two main mechanisms. 1, increasing GLUT4 on the skeletal muscle and adipose tissue, and 2, increasing glucokinase activity in the liver, hexokinase equivalent at liver, which pulls glucose out of the body to be stored as glycogen. Increasing fatty acid and protein synthesis, also increasing the lipoprotein lipase activity, fat storage. It causes dephosphorylation of enzymes. I talk about this in detail in my high-yield biochem PDF. Insulin secretion is high yield. Glucose enters the beta islet cells via GLUT2, leading to an increase in ATP production within the beta islet cell, which leads to closure of the ATP-gated potassium channel on membrane of beta islet cell, leading to potassium builds up inside the cell. More positive charge in the cell, leading to depolarization of the cell, which causes the calcium to move into the cell and triggers insulin vesicle efflux from cell. Now, insulin is normally produced as a propeptide that must have C-peptide cleaved off as part of the process. C-peptide and insulin are co-secreted, meaning their serum levels should match one another. If the patient has an increased insulin but a decreased C-peptide, the answer would be exogenous injection. If the C-peptide is normal or high, insulin production is endogenous. Make sense? First step is checking serum hypoglycemic levels, like serum hypoglycemic equals type 2 diabetes, type 2 diabetes med that decrease glucose, such as sulfonylureas and metaglutinides. If serum hypoglycemics are negative, then do CT of abdomen to check for insulinoma. Insulinoma and increased insulin in general cause Whipple triad of hypoglycemia, symptoms of hypoglycemia like tachycardia and tremulousness, and improves with meal, gets worse between meals. Insulin is absent in type 1 diabetes and is significantly increased in early type 2 diabetes, i.e. hyperinsulinemia. Insulin inhibits ketone formation, so we have a decrease in ketones in type 2, but an increase in ketones in type 1, which is why you can get diabetic ketoacidosis in type 1. Hyperinsulinemia causes anovulation/polycystic ovarian syndrome. See my reproduction PDF. USMLE can show you a pic of an acanthosis nigricans, which is almost always due to insulin resistance. Patients with chronic pancreatitis and pancreatectomy can have diabetes, loss of pancreatic tail. What about the arch nemesis of insulin we think of as glucagon? Glucagon secreted by alpha cells of the pancreatic tail. Remember that insulin's in the beta cells, so this is from the alpha cells. Glucagon's from alpha cells of the pancreatic tail. Causes an increase in serum glucose and phosphorylation of enzymes. Glucagonoma will present as an increase in serum glucose and a body rash called necrolytic migratory erythema. Don't confuse with the facial flushing seen in VIPoma. In addition, VIPoma doesn't increase glucose levels. Patients who receive insulin for diabetes can sometimes have prolonged or exaggerated hypoglycemic effects. If this occurs, an answer for why this occurs on USMLE is lack of counter-regulatory glucagon. Sounds weird, but it shows up more than once on NBMEs. Essentially, patients with diabetes or chronic pancreatitis or pancreatectomy, and not just prone to losing the beta islets, but they can also lose the alpha cells. When glucose goes down, glucagon should go up to compensate. But if this can't happen, glucose stays low. Question on NBME with chronic pancreatitis, chronic burnout from repeated acute pancreatitis, discussed more later, wants you to know that the arrows are decreased insulin production, decreased glucagon production, no change peripheral response to insulin. What about somatostatin? secreted by the delta cells of pancreatic tail. Decreased secretion of most GI hormones as well as growth hormone. Somatostatinoma presents as steatorrhea, probably due to the decrease in pancreatic lipase secretion. Octreotide is a somatostatin analog that can be used in addition to endoscopic banding for esophageal varices treatment. Leads to a decrease in portal blood flow pressure. That is true. You can also use it for other things like a VIPoma, which they don't mention here, but because it's basically trying to halt and undermine hormone release. And that's why it says, for example, too, it talks about growth hormone, it suppresses growth hormone. That's why you can use it if you have something like, let's say, for example, acromegaly. You can use octreotide, because acromegaly is when you have excess growth hormone. Do you need to know that for this exam? I don't know. Ghrelin, produced by the enteroendocrine cells of GI tract. All you need to know is that this hormone makes you feel hungry. Blood levels are highest at the start of the meal. USMLE will show you a graph of the ghrelin levels, and they ask you where on the graph corresponds to the start of a meal. And the answer is at the peak. Not complicated, but I've seen innumerable students get this wrong. So again, let me read that. I just want to make sure that I'm getting this right too. Blood glucose levels are highest for ghrelin. All you need to know is that the hormone that makes you feel hungry. Ghrelin are highest as you start of the meal. It shows you a graph of the ghrelin levels, and then you ask it where the graph corresponds to start of the meal. So the answer is the peak of ghrelin is at the beginning of the meal, because it's supposed to try to make you hungry. So it's not during the middle of the meal, it's at the beginning of the meal. Leptin, produced mostly by adipocytes, makes you feel full, i.e. opposite of ghrelin. Also plays an important role in hypothalamic / anterior pituitary secretion of gonadotropins. Leptin is decreased in those with low BMI / anorexia. You have a decrease in gonadotropin releasing hormone and a decrease in luteinizing hormone and LH and FSH, follicle stimulating hormone, leading to amenorrhea. The way I remember it, this is sort of silly. You mentioned ghrelin right here. I always remember it as like a ghrelin goblin, and it's hungry because it's a goblin. And then I think about like a leptin lemur. And lemur is more like just kind of chill, not really doing anything. You know, maybe it's like eating some sort of vegetation. It's very low key. It's not really doing anything. It's pretty satisfied. Is that kind of a silly thing? Yes, but you know, all this sort of learning mnemonics are kind of silly, to be fair. Most of them are. So anyway, next section, peptic ulcers, high yield causes. Peptic ulcers, high yield causes. Peptic ulcer is an umbrella term that refers to both duodenal and gastric ulcers. Gastric ulcers cause pain immediately with meals due to the increase in acid secretion. Patients can sometimes lose weight due to aversion to pain from eating. Duodenal ulcers cause pain 1 to 2 hours after meals due to an increase in acid entering the duodenum. With meals, the pylorus tightens, thereby relieving any residual discomfort. Patients may gain weight since eating decreases the pain. Helicobacter pylori, responsible for almost all duodenal ulcers, more than 95%, H. pylori, whereas it causes a lower percentage, only 60%, of gastric ulcers. This is merely because the latter are caused by many other things as well, so we simply have a decreased fraction caused by H. pylori. In other words, there's a no special tropism of H. pylori towards duodenal over gastric mucosa. It's just that there's more stuff that targets gastric mucosa that it has to kind of share that potential diagnoses we have to consider. It does both, but other things do gastric region. So when you do a graph, it is what it is. Mechanism for ulcers that show up on USMLE is secretes proteinaceous substrates that damage mucosal lining. This is correct over increased gastric acid secretion. If both are listed side by side, even though H. pylori does increase gastrin levels, which increase acid secretion, produces urease, which causes increase in ammonia production around the organism, allowing it to survive in the decreased low pH of the stomach. Antral/pyloric ulcers can lead to gastric outlet obstruction. They will mention this in a surgery question as a seclusion splash. Elevated risk of malt lymphoma, also called a maltoma, a type of B-cell lymphoma. Diagnose H. pylori with urease breath test or stool antigen. Treat H. pylori with a CAP, clarithromycin, amoxicillin, and PPI, like omeprazole. USMLE really, by the way, clarithromycin is a macrolide for reference, by the way. USMLE really doesn't care about the treatment, but CAP is safe to know. Again, clarithromycin, amoxicillin, and like omeprazole or another PPI. Metronidazole, tetracycline, bismuth, and PPI. Tetrad is used if CAP fails. Students ask about those other drugs, and metronidazole, tetracycline, bismuth, PPI is a backup. Perforated duodenal ulcer will present as a sudden onset of rigid abdomen, involuntary guarding. Patient will often have an SIRS with abnormal vitals due to the sympathetic activation. USMLE wants X-rays of the chest and abdomen to look for air under the diaphragm. High yield finding that indicates a ruptured viscus. It indicates ruptured viscus, okay. Gastronoma. Zollinger-Ellison syndrome causes recurrent duodenal ulcers and sometimes jejunal or ileal ulcers. Can be part of the MEN1 or idiopathic. H. pylori is more common than gastronoma. As mentioned above, greater than 95% of duodenal ulcers are due to the H. pylori. There is an NBME question where they give older males with a duodenal ulcer plus no other information, plus they ask for most likely cause. The answer would be testing for H. pylori. Gastronoma would be wrong. Vignettes can be tricky with gastronoma and tell you the patient has an 8 to 10 watery stools daily, where you say, that sounds like VIPoma. But they'll also tell you that patients has a history of abdominal pain after meals. Question on IM, Form 8 does this as example. NSAIDs causes gastric ulcers. I haven't seen these cause duodenal ulcers in USMLE, but they can cause gastric, I guess, according to USMLE. Prostaglandins are necessary for stimulation of gastric alkaline mucus production and maintenance of the gastric lining. NSAIDs can lead to a decrease in prostaglandin production and disruption of gastric lining. Because there's a certain kind of prostaglandin, I think, one of these things, I don't know which one it was, but it's involved in cytoprotection of the gastric lining, right? So that it protects the cells from being destroyed by the gastric acid. And that's being impaired by NSAIDs. The production of that thing is being impaired. So, decrease in prostaglandin production, disruption of the gastric lining. This can lead to both ulcers and irritation, gastritis. USMLE wants you to know that PPIs are first line for ulcer treatment in general, but the misoprostol is a PGE1 analog that is used in NSAID-induced ulcers, i.e. we're just replenishing the decreased prostaglandins from NSAIDs. So misoprostol is like a PGE1 analog. So if you have low PGE1, or whatever prostaglandins might be involved, I guess PGE1 being the one to be aware of, I suppose, in terms of medical as we're concerned, that has a cytoprotective effect, but if that's deficient, you can give this misoprostol as a thing to help you with that situation. Burns, rare, but just know they exist. Called curling ulcers, think curling irons are hot. Loss of fluid post-burns from evaporation, leading to a decrease in blood flow to the stomach, leading to ischemic ulcers. Head trauma, rare, but just know they exist. Head trauma or brain tumor leads to an increase in intracranial pressure, leading to an increase in parasympathetic outflow to the stomach, which leads to an increase in acetylcholine binding to muscarinic receptors at parietal cells, leading to an increase in acid production. Do not forget that the three synergistic mechanisms for acid production are 1. Gastrin binding directly to gastroreceptors on parietal cells. 2. Gastrin stimulating enterochromaffin-like cells, ECL cells, to secrete histamine, which then binds to the H2 receptors on parietal cells. And 3. Direct parasympathetic activity, where acetylcholine binds to muscarinic receptors on parietal cells. Smoking/alcohol. Not tested as an overt cause of ulcers on USMLE, but you should know that the smoking and alcohol are believed to decrease healing of pre-existing ulcers. Okay, and now we are on page 116. We've gone in about an hour. I think it says now, 56 minutes. Okay. We're on page 117. We have made a good deal of progress, I think. I kind of want to retire for the night, and I'll get to the rest of it hopefully tomorrow. So if you like this video, I don't know, smash that like button, I guess. Subscribe. I don't know. What else could you... Make a positive comment? I don't know. Off your daughter's hand in marriage to me? I don't know. Whatever floats your boat, you know? Anyways, but hopefully this video is useful to you, and hope you have a great rest of your night. Thank you, and goodbye.